Welcome to the January 2022 Safety Stand Down. This month we are working with the IAFC and going over some information about COVID and how it's impacted firefighters specifically across the country. Safety stand downs occur when the fire service sees a risk to firefighters so alarming that it requires focused national attention and call to action by firefighters across the country. A stand down was called to highlight an urgent call to action for the fire service to educate and encourage firefighters on the need for all fire and EMS personnel to get vaccinated against COVID-19. David Mayfield and I will be going over this information and telling you about what our local situation is and then what's going on across the country.
Hello everyone. This session we're going to be discussing the case counts nationally as well as locally for the pandemic since last month. The U.S. is experiencing our fifth surge with daily case counts surpassing the prior pandemic by fourfold. The daily 7-day average of new infections has been ranging between 800 and 750,000 new cases a day. 2/3 of the states had a double-digit increase in the past week, with the largest jumps found among states in the Midwest, West, and Mountain West. COVID-19 hospitalizations in the U.S. set another record high this past week, with the good news of new admitted patients that may have reached a national peak, with early indicators of those new admissions dropping. Deaths continue to climb since November, but not at a rate seen back in January of 2021. Unfortunately, some models estimate that the total number of new deaths could rise above 1 million by mid-March, when some experts believe that the Omicron variant will begin to subside. Looking locally at Georgia, cases throughout the state plateaued about 2 weeks ago and began to show signs of decreasing from the peak last Friday until yesterday, when the state uploaded a large amount of cases. Hospitalizations remain stable and may be at peak or passing peak very soon. Admissions for COVID still remain very high, with nearly 30% of all hospitalized patients having COVID-19. We're only a couple of hundred patients shy of matching the second highest census since January of 2021. The positivity rate among those tested for COVID remains very high at 30%. Metro Atlanta area hospitals are seeing rates in the teens to 20s, and the coastal counties are having percentages well in the 40s. Community transmission is very high to extremely high in every county in the state, and deaths have been flat since December.
Part of the reason for this safety stand down is that 3 times more firefighters have died of COVID-19 infection since the beginning of the pandemic than died on duty from cardiac events, the typical leading cause of on-duty death for firefighters on an annual basis. At one point in the pandemic, we were losing a firefighter from COVID-19 approximately every 48 hours. 5 firefighters have been documented to have fallen to COVID-19 in 2021. These firefighters represent more than half of all Georgia firefighter deaths in the last year. To date, 240 firefighters in the United States have died due to COVID-19. If we had seen this many firefighters killed by any other cause, there would be no question whether we would do a safety stand down or whether that's necessary. Here at Atlanta Fire Rescue, we decided to tackle this process very early on in COVID-19 in March of 2020. And we have been trying to keep you updated as much as possible going along through these times. So, published in the Journal of American Medical Association, a study conducted in Arizona among pre-vaccinated healthcare workers, first responders, and other essential workers found first responders had twice the incidence of infection as healthcare personnel and 60% and higher when adjusting confounding factors such as hours worked and the time within 3 feet of others. While mitigating measures such as social distancing, masking, ventilation, and aggressive attention to hygiene may have an impact on decreasing the spread of COVID, no measure is as effective as vaccines for reducing the toll of death and disease on firefighters. Yet, there remains concern among fire and EMS personnel about the safety, the efficacy, and the impact of the vaccine. There has been wide concern about how quickly the vaccines were developed. Mixed messages were sent about how the vaccines work and how effective they are at preventing the vaccine and severe illness, and how serious the disease is or can be for otherwise healthy firefighters. There are currently 2 vaccines available, Moderna and Pfizer, that are being used based on mRNA. These vaccines use messenger RNA to train your cells to recognize the virus and provides a blueprint of how to fight it if it is introduced into the body. Johnson & Johnson uses a viral vector approach. The J&J vaccine involves the use of another common virus that has been modified with the blueprint genetic material to infect cells and simulate an immune response. So, the speed at which the vaccines were brought to market has been raised as a cause of concern. Suggestions have been that it was rushed, skipped, and the approval stages typical of other or more common vaccines. In truth, the speed of the process can be attributed to a number of factors and is a testament to how fast the process can be when all barriers are removed. Success in this instance were based on existing research in the field of mRNA vaccines. mRNA has been used in cancer treatment for over a decade. Vaccine development for SARS that has occurred since 2003 provided a head start for scientific teams that already had the foundation for how to tailor the vaccine to this particular coronavirus. I believe that you can remember when Dr. Bowers talked about this, and she says that a vehicle was already there. We were just looking for what needed the component for COVID-19 to be able to distribute that vaccine. This had unprecedented expedited funding. Companies were typically cautious to invest funds in testing and bringing drugs and vaccines to market unless they are certain that there will be a need. In this instance, the clear and present persistent need meant dedicated funds for development. Study recruitment was no issue because plenty of people participated in the trials. They required efforts for recruitment. Vaccine trials had more volunteers than they needed as the trials opened. Effective vaccine and rapid spread. There's another concern. While many trials require a long period of follow-up to determine if the active vaccine and placebo produced different effects, the difference was quickly apparent in the vaccine trial data given both the highly effective vaccine and the rapid spread of the disease. And then there was the expedited review. Review of the documentation thoroughly and quickly was prioritized with organizations such as the FDA, and they were hiring additional staff to ensure standard protocols were followed. Concurrent ramp-up for manufacturing occurred, which given the early positive promise of vaccine efficacy. So research on the number of doses that will eventually be needed in the series of ongoing as a scientist study how long the immunity is elevated. Many vaccines in the past have required a series of shots. For example, a full polio dose is a series of 4 vaccinations. Currently, the CDC recommends that those who received an mRNA vaccine may want to get a 3rd shot if they are 18 years old or older and work as a first responder, depending on their individual risk factors. These should be Another mRNA vaccine at least 6 months after the shot. It is recommended that anyone who received the Johnson & Johnson vaccine and is 18 years old or older receive a booster 2 months after their shot. You're encouraged to talk to your doctor about your health and what is right for you. So then there's the vaccine side effects. How likely is that there will be long-term side effects and things that haven't been identified yet? The vast majority of the vaccine side effects occur within the first 72 hours of the vaccination. There have been drugs in the past that ended up having unintended long-term side effects. It is not uncommon to see ads or billboards stating, if you've taken this drug in the past, you deserve compensation, for class action lawsuits against drug companies. The difference between these types of drugs and vaccines is that the danger of the drugs typically occurs because they are taken repeatedly over a long time, and as the drugs build up in the system, there are negative consequences. Vaccines work in a different way. They are introduced into the body, they train the immune system, and they leave the body within 48 hours. Therefore, there is not a buildup of vaccine over time. Serious side effects from COVID vaccines are rare, but they are closely monitored. As you can remember, if you've had the COVID vaccine, you would walk in and you'd get your shot, and then you're going to sit around for at least 15 minutes to make sure that you're not having a negative side effect immediately. But both in the clinical trials and once the vaccine's rolled out, side effects were closely monitored. The VAERS system is set up to collect side effects from both healthcare settings and the general population. Adverse health outcomes are documented in that system and investigated. A benefit of the system is that trends in adverse side effects can be quickly identified and monitored, although it should be noted that every entry into the system is a result of the vaccine. For instance, several have notes that patients were already on hospice when they were vaccinated. A pause in the distribution of J&J occurred after only 6 cases of thrombosis were identified. So you can see that our representatives in government, FDA, and CDC were closely monitoring this and making sure that these were safe to be used. Then there was this talk about myocarditis. Myocarditis is inflammation of the heart muscle or myocardium that can result in hospitalization, heart failure, and sudden death. The common symptoms included shortness of breath, chest pain, feelings of fast beating, fluttering, pounding heart. Myocarditis is a rare disease, 4 to 6 cases per 100,000. Usually, 50 to 70% of cases caused by viral infections, and most common among young adult males. Concerns have emerged about the development of myocarditis after the receipt of mRNA vaccines, typically among young adult males after the second dose, with symptoms occurring several days post the vaccine. Or not. Myocarditis after the vaccine versus an infection. Younger people are particularly vulnerable to myocarditis due to a COVID-19 infection. The relative risk is 37 times higher for infected children under 16. The relative risk is 7 times higher for infected people ages 16 to 39. So importantly, vaccines do not have to be highly effective to save thousands of lives and prevent millions of infections. For instance, polio in the U.S. is largely eradicated. The high rate of success is partially due to the vaccine and partially due to the high rate of vaccination. There are fewer people contracting the disease, so less chance of coming in contact with someone who has it. So, what is the benefit of getting the vaccine? Vaccines reduce the risk of COVID-19, including the risk of severe illness and death among people who are fully vaccinated. In addition to data from clinical trials, evidence from real-world vaccine effectiveness studies show that COVID-19 vaccines help protect against COVID-19 infections with or without symptoms. Vaccine effectiveness against hospitalizations has remained relatively high over time, although it tends to be slightly lower for older adults and for people with weakened immune systems. While it's true, that concurring disorders are at a higher risk for severe outcomes and death from COVID, living a healthy lifestyle cannot prevent being infected and does not guarantee a lack of symptoms with COVID. Even among professional athletes, a small number exhibited myocarditis tied to their infection. Beyond self-protection, vaccines are important to reduce the spread of COVID to others in the community. With an introduction of the Delta variant, the spread of COVID has been significantly faster. And as you can see, we've talked about Omicron has even surpassed the Delta variant in how quickly and rapidly it was ramping up and infecting people. The initial variant had R0 pronounced Rho, not. An estimate number of people, each person with infection will spread to the disease of approximately 2. So each infected 2 others. The Delta variant estimates are closer to 8. And they're still working on Omicron to see what those estimates will be later on. High community spread can also lead to additional mutations of the virus. Although COVID-19 is typically mild in young people, about 30% of youth hospitalized with COVID-19 have no underlying health conditions that would have put them at increased risk. Amid the recent Delta surge, hospitalization rates were about 10 times higher than in unvaccinated young people than in vaccinated ones. There are treatment advances, including the use of new medications and monoclonal antibody treatment. So what are those treatment approaches? What's good? Do you have to worry about getting sick? It is important to remember that the treatments are not always available to everyone in every region and often require early treatment. For instance, monoclonal antibody treatment is often given early to people at high risk of hospitalization and to decrease the risk of death. Also, the FDA has authorized 2 antiviral pills recently for those who are mild to moderately ill and to take these pills at home before they get sick enough to be hospitalized. These antiviral pills are currently being distributed to states in very limited quantities until production can meet the demands. The FDA emphasized these new antivirals are not a substitute for the vaccination. Do you still benefit from a vaccine if you already had COVID-19? Is a huge question that is in the minds of all of our members and all of the public. While infection with COVID goes to produce an immune response and can promote immunity, studying people post-infection has found that the level of immunity varies across people and the amount of time the immunity lasts is also inconsistent. If you had COVID-19 before and are not vaccinated, you are twice as likely to be infected with COVID again compared to those who have had both the infection and the vaccine. The large study conducted in 9 hospitals found that prior COVID-19 infection does not protect as well against reinfection as the vaccines. Currently, it is recommended that those who have been infected with COVID-19 also get vaccinated, and they refer to this as a hybrid immunity to maximize the protection. So, why fire and EMS? Vaccines are especially important for fire and EMS personnel for a number of reasons. They're patient-facing and are widely engaged in their communities. While other Americans are encouraged to stay home, fire and EMS come to work and they are at risk when they go out there on the front lines. Their ability to spread the viruses to each other and the community makes the infection as a higher for them as in the general population. We go to work in places that are not clean to the highest standards. Where other people work in hospitals and they're clean on a regular basis with a specified chemicals to be cleaning. So we don't get the opportunity to work in those same environments. So we are taking a much higher risk when we go out there. Therefore, it's important that we have the vaccines and it's important that you wear the proper PPE when we're going out on these calls. COVID-19 will continue to mutate. The more chance it has to spread, the higher the likelihood that it will mutate to something that cannot be thwarted by the current vaccines and or mutate into a more dangerous variant, which could pose a serious setback to the pandemic efforts. Fire and EMS often interact with the most vulnerable, the elderly, the immunocompromised. So those are all areas where we are putting ourselves out there to try to take care of the public, and we are at risk. We are at risk when we fight fires. We are at risk when we go to hazardous material calls. And we provide those PPEs for you to make sure that you're taken care of. We provide hepatitis vaccines so to make sure that you're protected from hepatitis. And we check to make sure that you're protected from TB, that you haven't had it. And if you have, we get you with the medical personnel to make sure you get the medications you need to protect you from that in the future, to make sure it doesn't get any further. Here in the Office of Safety and Health, we take that very seriously. As you can see, we've consistently had our annual physicals looking for those things, and each year we find something in someone in our department that saves their lives due to the health and wellness things that we do with our department. It is important for us. If you do have questions, we have also resources with the IAFC, the International Association of Fire Chiefs, and you can send the questions to Chief Scott Kerwood. He's the chair of the Safety, Health, and Survival section of the IAFC, and you can see his email there on the screen. This was developed by the Center for Fire Rescue and EMS Health Research in the IAFC, and we want to thank you for the support that the National Fallen Firefighters Foundation and the Assistance to the Firefighters Grant Program has been in developing this information. Thank you for your time. We appreciate you coming to work. We appreciate you taking care of the citizens of Atlanta, coming to work and keeping this area safe. That's it for this month's edition of the Safety Stand Down. We appreciate your time. Take care. God bless.